Okay, so this gets us to the next question, that is question 41. Question 41. Organism responsible for endocarditis after early prosthetic heart valve replacement. B. Staph epidermidis. So I can divide this as an important set of questions. I can divide infective endocarditis into two types. Infective endocarditis, it is of two main types: acute infective endocarditis and subacute infective endocarditis. Acute, subacute. Acute infective endocarditis, it occurs in an undamaged heart, whereas subacute infective endocarditis, it occurs in a partially damaged heart. Next point, as a result, a less virulent organism is causing infection in subacute, whereas a more virulent organism causes in acute. And the most common organism in acute infective endocarditis is Staph aureus, whereas in subacute it is Strep viridans. In subacute infective endocarditis, the most common organism is Strep viridans. Staph aureus versus Strep viridans. Next point, most common organism after prosthetic heart valves. I can divide prosthetic heart valves into two types: early prosthetic heart valves and late prosthetic heart valves. Most common organism after early prosthetic heart valves is Staph epidermidis, whereas after late prosthetic heart valves, this is the same as a partially damaged heart, that is Strep viridans. After late prosthetic heart valves, Strep viridans. So the answer to question 41, organism after early prosthetic heart valves, Staph epidermidis. Next. Next, question 42. Lymphomatoid polyposis. It is a characteristic feature of mantle cell lymphoma. So, starting with mantle cell lymphoma. First point, it is a B cell NHL. It is a B cell non-Hodgkin's lymphoma. Next point, the most common translocation associated with mantle cell lymphoma is translocation 11-14. Next, it is positive for the expression of BCL1 protein, and it is also cyclin D1 positive. Next, the next question is cyclin D1 negative mantle cell. Which marker is positive in this? SOX11. In cyclin D1 negative mantle cell lymphoma, it is SOX11 positive. Next point, markers in mantle cell. Markers in mantle cell lymphoma. First point, it is CD5 positive but CD23 negative. Extremely important. So the best marker to differentiate CLL from mantle cell lymphoma, the best marker to differentiate CLL, that is chronic lymphocytic leukemia, from mantle cell lymphoma is CD23. How? Because CLL or chronic lymphocytic leukemia, CLL, this is CD5 positive, CD23 positive, whereas mantle cell lymphoma, it is CD23 negative. So the best marker to differentiate CLL from mantle cell lymphoma is CD23. Next. Next, this gets us to question 43. This gets us to question number 43, and the answer is maternal disomy. It is seen in Prader-Willi syndrome. It is seen in Prader-Willi syndrome. So before we go further, let us have a look at what this is. Here we are discussing genomic imprinting. Genomic imprinting. Genomic imprinting, this is a type of non-Mendelian inheritance. This is a type of non-Mendelian inheritance. First point. Next, the gene that is getting imprinted, is not expressing itself. It is not expressing itself. The gene that is imprinted is not expressing itself. So if you know this, you will know everything about it. How? Genomic imprinting, the main diseases associated with this are Prader-Willi syndrome and Angelman syndrome. Prader-Willi and Angelman syndrome. First point, both of these, Prader-Willi as well as Angelman, they are associated with chromosome 15 mutations. Next point, easy to remember, Prader-Willi is maternal imprinting, whereas Angelman is paternal imprinting. We're talking about genomic imprinting. So we will make the mnemonic with respect to imprinting. P and P do not go together. Prader-Willi, maternal imprinting, Angelman, paternal imprinting. So Prader-Willi syndrome, it is maternal imprinting. The gene from the mother is physically present, but it is not expressing itself, with paternal deletion. Whereas Angelman syndrome, it is paternal imprinting plus maternal deletion. So see the question properly. Paternal deletion is Prader-Willi, whereas maternal imprinting is Prader-Willi. Next point, question asked you about disomy. So the first way of having the disease is by deletions. The next way of having the disease is by disomy. Disomy matlab both the chromosomes are coming from the same parent. So in Prader-Willi, both the chromosomes are coming from the mother because they are physically present but not expressing themselves. So Prader-Willi is maternal disomy, whereas Angelman is paternal disomy. Angelman syndrome is paternal disomy. Done. This gets us to the next question. This gets us to the next question, that is question 44. Histiocytic necrotizing lymphadenitis. This is a one-liner and a spotter. It is Kikuchi disease. You very well know Kikuchi disease. It is histiocytic necrotizing lymphadenitis. It is histiocytic necrotizing lymphadenitis. Kikuchi disease. Histiocytic necrotizing lymphadenitis. It is a benign self-limiting disease. It is a benign self-limiting disease which affects younger females. Benign self-limiting which affects younger females. On the other hand, Kimura's disease, it is more common of unilateral cervical lymphadenopathy. On the other hand, Kimura's disease, this is most commonly manifesting as painless unilateral cervical lymph node enlargement. So Kimura's painless unilateral cervical lymphadenopathy. This again affects young to middle-aged adults. It affects young to middle-aged adults. Plain and simple. So the answer is necrotizing lymphadenitis or histiocytic necrotizing lymphadenitis, Kikuchi disease. Next. Next. This gets us to the next question, that is question 45. First change in vessels in acute inflammation. We have already seen this. It is vasoconstriction. The first change in the vessels is vasoconstriction followed by vasodilation. We have already seen this. Next point, the most common vessel affected. They are the post-capillary venules. The most common vessel affected, post-capillary venules. Next point, most common mechanism of increased permeability. It is immediate transient in nature. Most common mechanism, immediate transient. Most common mediator causing an immediate transient release, histamine. Most common mediator causing an immediate transient release histamine. Plain and simple. So the answer is vasoconstriction. Next. This gets us to the next question, that is question 46. Which of the following does not present with systemic eosinophilia with renal failure? And the answer is PAN. Polyarthritis nodosa or PAN. The other options, that is drug-induced interstitial nephritis, atheroembolic renal disease and contrast allergy induced nephropathy. All of these are associated with eosinophilia and renal failure, whereas the PAN is not. Polyarthritis nodosa, let us see few points with this. You already know it is a medium vessel vasculitis. It is a medium vessel vasculitis. Next point, most common cause of death. Most common cause of death, it is renal artery involvement. Most common cause of death, renal artery involvement. Next point, PAN, organs involved. Organs involved. It affects the kidney and visceral vessels. PAN, it affects the kidney and visceral vessels. Extremely important point, lungs are spared. This is extremely important. Lungs are involved in microscopic PAN, but they are spared in PAN. Plain and simple. So these are the main points with polyarthritis nodosa. You already know it has two phases, an acute phase and chronic phase. PAN, it has two phases, acute phase and chronic phase. These acute and the chronic phases, they coexist. That is, at the same point in the body, somewhere there would be an acute phase, somewhere there would be a chronic phase. This is PAN or polyarthritis nodosa. Next. This gets us to the next question, that is question 47. Question 47. Marker of open neural tube defect. Answer is A, that is increased acetylcholinesterase. Marker of open neural tube defect, it is increased acetylcholinesterase. This is just a one-liner that needs to be remembered. Next point, question 48. Question 48. We have already seen this subtype of RCC associated with chromosome 3p deletion, clear cell carcinoma. Associated with chromosome 3p deletion, clear cell type carcinoma. That is option C. You very well know there are three main types: the conventional or the clear cell type RCC, conventional or the clear cell type, which is associated with chromosome 3 or VHL mutations, that is von Hippel-Lindau mutations. Next, papillary RCC associated with chromosome 7 or CMET mutations. Papillary RCC associated with chromosome 7 or CMET mutations. And the last main type is the chromophobe RCC. Associated with, it is phobic of the chromosomes, so associated with deletions or hypodiploidy. Associated with deletions or hypodiploidy. So these are the three main types of renal cell carcinomas. So easy question. Subtype of RCC with 3p deletion, clear cell RCC. Next, question 49. Question 49. P ANCA is associated with all except Wegener's granulomatosis. That is option D, Wegener's granulomatosis. So I can divide ANCA into two types. I can divide ANCA. ANCA stands for anti-neutrophil cytoplasmic antibody. Anti-neutrophil cytoplasmic antibody. ANCA. ANCA vasculitis, I can divide it into three main types. C ANCA, that is cytoplasmic ANCA. P ANCA, that is perinuclear ANCA, and atypical ANCA. So C ANCA, P ANCA, atypical ANCA. The disease associated with C ANCA is Wegener's granulomatosis. C ANCA, Wegener's. P ANCA, microscopic pan and Churg-Strauss syndrome. P ANCA, microscopic pan and Churg-Strauss syndrome, and atypical ANCA, that is inflammatory bowel disease. PSC, that is primary sclerosing cholangitis, and RA, that is rheumatoid arthritis. So the question asked you, P ANCA is associated with all except, please don't get confused with IBD or ulcerative colitis, it can have a subtype of P ANCA. The answer is Wegener's granulomatosis because it is C ANCA positive. Because it is C ANCA positive. Next point. Coming to the next question, that is question 50. Question 50, which is not a feature of apoptosis, cellular swelling. That is option B, cellular swelling. You very well know apoptosis. Apoptosis, it is programmed cell death. Apoptosis is programmed cell death, which is caspase mediated, which is mediated by caspases. Programmed cell death mediated by caspases. Next point, in apoptosis there is no inflammation that is seen. In apoptosis there is no inflammation versus necrosis, which shows inflammation. Next point, gel electrophoresis. Gel electrophoresis in apoptosis shows the classical step ladder pattern. Gel electrophoresis in apoptosis shows the classical step ladder pattern. Next point, microscopically it is associated with cell shrinkage, not cellular swelling. Microscopically it is associated with cellular shrinkage. The other options, that is cytoplasmic eosinophilia, intact cell membrane and nuclear compaction, they are also seen, but it is cell shrinkage. Next, coming to the next question, that is question 42. Not a action of bradykinin. It does not cause bronchodilation. It does not cause bronchodilation. On the other hand, bradykinin, the main roles of bradykinin are, it is responsible for pain. Next, it is responsible for vasodilation, increased vessel permeability, and bronchoconstriction. Point to be noted is, it is not associated with bronchodilation. Next, this gets us to the next one, that is question 52. Question 52. Anti-LKM antibodies, they are seen in hepatitis C virus infection. Anti-LKM antibodies, they are seen in hepatitis C virus infection. So, anti-LKM1, LKM stands for liver kidney microsome 1 antibody, that is anti-liver kidney microsome 1 antibody. ALKM1 or anti-LKM1, it is seen in autoimmune hepatitis. Autoimmune hepatitis is of 3 types, type 1, type 2, type 3. Most common is type 1, but anti-LKM1, it is seen in autoimmune hepatitis type 2 and hepatitis C virus infection. So, anti-LKM1, autoimmune hepatitis type 2 and HCV. Next point, ALKM2, that is anti-LKM2 antibody. Anti-LKM2 antibody, it is seen in drug-induced hepatitis. Whereas anti-LKM3 antibody, it is seen in chronic hepatitis D virus infection. Plain and simple. Anti-liver kidney microsome 1 antibodies. Next, this gets us to the next one, that is question 53. Most specific marker of myeloid series, CD117. So, coming to the list of markers, this list of markers is important, starting with B cell markers. starting with B cell markers. Pan B cell marker. Pan B cell matlab it is positive on all the B cells. CD19. CD19. Next, mature B cell marker, positive on the mature B cells, CD20. Whereas immature B cell marker, CD10. So pan B cell marker, positive on all the B cells, CD19. Mature, which is positive on mature B cell, CD20. Immature B cell marker, CD10. Next point, T cell markers. T cell markers. T cell markers. Pan T cell marker present on all the T cells, CD3. Other T cell markers, you very well know T cells are of two main types, CD4 positive, which are the helper T cells, CD8 positive, which are the cytotoxic T cells. Others are CD2, CD5 and CD7. So all the single digit markers 4, 8, 2, 5, 7 T cell markers. Next, myeloid marker. Let me use a different ink for this. Myeloid markers. Myeloid markers. The myeloid specific marker. The myeloid specific marker is MPO, that is myeloperoxidase, whereas myeloid associated is CD117. So the question asked you most specific for myeloid series, among the options answer is CD117. Why? Because CD45 it is the leukocyte common antigen. CD45 it is the leukocyte common antigen, also called as LCA, leukocyte common antigen, present on all the leukocytes. Next, CD34 and CD99. CD34 and CD99, they are stem cell markers. CD34 and CD99, they are the stem cell markers. So answer is CD117. Next, coming to the next question, that is question 54. MYC2 mutation, it is seen in Ewing's sarcoma. MYC2 mutation, it is seen in Ewing's sarcoma. That is option B. You very well know CA15-3. Coming to the various other tumor markers, CA15-3 is for breast cancer. So MYC2, Ewing's. Ewing's, you know, it is a diaphyseal tumor of the bones. This is a diaphyseal bone tumor. Diaphyseal bone tumor. Another important question that is asked with Ewing's sarcoma is which CD marker is positive in this? CD99. Ewing's sarcoma, it is CD99 positive. Next point, coming to the other tumor markers or other markers seen with cancers. CA125. CA125 ovarian cancer. CA125 ovarian cancer. CA199 pancreatic cancer. CA19-9, pancreatic cancer. So these are the other markers which are present in these locations. Next, this gets us to the next question, that is question 55. Most common retroperitoneal tumor. This is a factual question and the answer is liposarcoma. Liposarcoma. This needs to be remembered. The most common retroperitoneal tumor. Most common retroperitoneal tumor. It is liposarcoma, which accounts for 40% of all retroperitoneal tumors. This is followed by leiomyosarcoma. This is followed by leiomyosarcoma, which accounts for 25%. So, most common liposarcoma, which is followed by leiomyosarcoma, which accounts for 25% of all tumors. Next point. Next. This gets us to the next question, that is question 56. Which stain is used to study fungal morphology, that is PAS? Answer is periodic acid Schiff. Now the point to be noted is PAS, it stains both. PAS or periodic acid Schiff, it stains both the living as well as the dead fungi. Periodic acid Schiff or PAS, it stains both living as well as dead fungi. Whereas your next option, methenamine silver or MS, it stains only the living fungi. Methenamine silver, MS, it stains only the living fungi. We already know von Cosa and alizarin redis. Von Cosa stain, this is most commonly used for calcium, whereas most specific for calcium is alizarin redis. Alizarin redis stain. Done. So last point, another option is Mason's trichrome. Let us see one point about this also. MT or Mason's trichrome. The name tells you everything. Trichrome, 3 colors. The 3 colors that we get in this are blue-green, which is for collagen, red, which is for muscle, and black, which is for nuclei. So Mason's trichrome, 3 colors: blue-green, collagen, red, muscle, black, nuclei. Done. So the answer was periodic acid Schiff or PAS. Next. This gets us to the next question. Most common cause of Downs. This is again a SWT. It is maternal non-disjunction. Downs. It is caused by maternal non-disjunction of chromosomes. You very well know Down's trisomy 21. Nothing to explain in this. It is maternal non-disjunction. You also know another statement with Downs. It is the most common genetic cause of mental retardation. Down syndrome. It is the most common genetic cause of mental retardation caused by maternal non-disjunction trisomy 21. Next, trisomy 18 Edwards, trisomy 13 Patau's. So, having a look at trisomies, trisomy 18 Edwards syndrome, whereas trisomy 13 Patau's syndrome. This you already know. Trisomy 18 Edwards, trisomy 13 Patau's. Next, this gets us to the next one. Caspases are involved in. This is again a spotter. We have pretty easy questions in the paper, no doubt about it, that they are involved in apoptosis. You very well know apoptosis. It is programmed cell death. Apoptosis. It is programmed cell death, which is mediated by caspases. Another important question that is asked is, this is important, caspase independent programmed cell death. Caspase independent programmed cell death. This is called as necroptosis. This is called as necroptosis. Caspase independent programmed cell death, necroptosis. Plain and simple. Next, this gets us to the next one, that is question 59. Question 59. There is male icterus hyperammonemia, uniform greasy cut, likely to show alcoholism. Answer is D, that is alcoholism. So, typical thing, there is a marked fatty change. Alcoholism, it is associated with fatty change in the liver. It is associated with fatty change in the liver. Next point, see, it is not tuberculosis because TB will show granulomas. It is not hemochromatosis because that is iron accumulation and it will show hemocysteine deposits on Prussian blue. It is not galactosemia. Why? Because it is not associated with fibrosis. So the answer is alcoholism. And alcoholic liver disease. Alcoholic liver disease, it has 3 stages. Stage 1, stage 2 and stage 3. Stage 1, it is called as fatty liver disease or steatosis. Fatty liver disease or steatosis. Stage 2 is steatohepatitis. Steatohepatitis. Stage 1, fatty liver disease or steatosis. Stage 2, steatohepatitis, whereas stage 3 is cirrhosis. Stage 3 is cirrhosis. Next point, what is the special name of cirrhosis that is seen in alcoholic liver disease? It is called as Lenac cirrhosis. It is called as Lenac cirrhosis. So alcoholic liver disease, it has 3 stages, 1, 2 and 3. Next point, another important point to be noted in this question. See, we have already seen answer cannot be TB or hemocidrosis. Why is the answer not galactosemia? The answer is not galactosemia because galactosemia it is associated with fibrosis. It is associated with fibrosis and it is typically seen in infants. Here in the question, neither fibrosis nor infants is mentioned. So the answer is alcoholism. Next, this gets us to the next question, that is question 60. COX-2, it is seen in cell proliferation. COX-2, it is seen in cell proliferation. So this has to be remembered. COX-2, it is a feature of cell proliferation. As a result, COX-2 inhibitors, they reduce cell proliferation. COX-2 inhibitors, they reduce cell proliferation. Plain and simple. This has to be remembered. COX-2, it is seen in, or it is implicated in cell proliferation. Next. Okay, this gets us to the next question, question 61. Question 61. Which of the following is disease associated with storage of non-functional protein in hepatocytes? Answer is B, alpha-1 antitrypsin deficiency. Answer is B. It is associated with storage of non-functional protein. So, in the liver, in the liver. This is associated with intracytoplasmic. It is associated with intracytoplasmic eosinophilic globules. Intracytoplasmic eosinophilic globules, which are also PAS positive in nature. These intracytoplasmic eosinophilic globules, they are periodic acid shift positive, or they are PAS positive. In the lungs, you very well know alpha-1 antitrypsin deficiency. It is associated with emphysema. Which emphysema? Pan-acinar emphysema. It is associated with pan-acinar emphysema. Next, it is also associated with subcutaneous panniculitis. It is also associated with subcutaneous panniculitis. Panniculitis matlab inflammation of the fat. So inflammation of subcutaneous fat seen in alpha-1 antitrypsin deficiency. Next, this gets us to the next question, that is, all are associated with trinucleotide repeats. All of the following are associated with trinucleotide repeats in non-coding region except spinocerebellar ataxia. Except spinocerebellar ataxia. This is important. The other three, Fragile X, myotonic dystrophy and Friedreich's ataxia, that is options A, B and D, they are seen in the, they are because of repeats in the non-coding region, whereas spinocerebellar ataxia and Huntington's disease, spinocerebellar ataxia and Huntington's disease, they are because of repeats in the coding region. Spinocerebellar ataxia and Huntington's disease, they are because of repeats in coding region, whereas Friedreich's ataxia, Fragile X and myotonic dystrophy, they are associated with repeats in non-coding region. Next, question 63. Question 63. Post-transplant lymphoma. This is extremely easy. Post-transplant, it is a B-cell NHL. It is a B-cell NHL. Nothing to explain in this. This is also called as B post-transplant lymphoproliferative disorders. It is a subtype of B-cell NHL. Next point. All these are the one-liners, so they were pretty simple. Next, question 64. Specific marker for synovial sarcoma. Translocation XL18. Synovial sarcoma, translocation X18. Next point, it produces SYT slash SSX1 or SYT slash SSX2 fusion product. Fusion product. This point is important. Synovial sarcoma. It is translocation X18 producing SYT-SSX1 or SYT-SSX2 fusion product. Next point, synovial sarcomas, microscopically they have a biphasic morphology. Microscopically they have a biphasic morphology. This is synovial sarcoma. Next, question, this gets us to the next one, that is question 65. This is again a spotter. Cryoprecipitate. It contains all of the following except factor 9. Except factor 9. Cryoprecipitate. It has factor 8. It has factor 8 fibrinogen, factor 8 fibrinogen and von Willebrand factor. All these three, they are present in cryoprecipitate, whereas it is deficient in factor 9. That is why cryoprecipitate, it can even be used in hemophilia type A. It can even be used in hemophilia A. You very well know hemophilia, it is of three types: A, B, C. Hemophilia A, deficiency of factor 8. Hemophilia B, deficiency of factor 9. Hemophilia C, deficiency of factor 11. So as cryoprecipitate has factor 8, so you can use cryoprecipitate in hemophilia A. That is when the factor 8 is not available. Next. Question 66. Which of the following characterizes eczematous reactions 72 hours after wearing latex? Answer is type 4 reaction. Type 4 reaction. You very well know type 4 reaction, it is delayed type of hypersensitivity. Type 4 reaction is a delayed type of hypersensitivity reaction mediated by macrophages. Mediated by macrophages, and the main cytokines responsible are interleukin 12 and interferon gamma. It is a delayed type of hypersensitivity, macrophages mediated, and it is seen in the cytokines involved are interleukin 12 and interferon gamma. As the reaction is taking place after 72 hours, it is type 4. Whereas if the reaction was within minutes, after wearing gloves, if the reaction was within minutes, then it would have been type 1 hypersensitivity reaction. Within minutes would have been type 1 hypersensitivity. Next. This gets us to the next one, that is question 67. Which of the following is not a neuronal tumor? And the answer is ependymoma. A, that is ependymoma. Easy, you very well know ependymoma, it is a glial tumor. Ependymoma, it is a glial cell tumor, or it is a glial tumor. Next point, another question that is asked from ependymoma is its microscopy. Microscopically, ependymoma, it shows the presence of perivascular pseudorosettes. This is asked. Ependymoma, it shows the presence of perivascular pseudorosettes. What do I mean by this? You will have the presence of cells in a rosette. All these are the rosettes, that is, it is a round cluster of cells with presence of a central blood vessel. With presence of a central blood vessel. This is a perivascular rosette. It is not a true rosette because it does not have a lumen. True rosette has a lumen, not a vessel. This is a pseudo rosette because it has a central vessel. Next. This gets us to the next one, that is question 68. Most commonly used fixative in pathology, and the answer is D, that is formaldehyde. Most commonly used fixative, formaldehyde. What percentage? It is 10% buffered formaldehyde. It is 10% buffered formaldehyde, that is the most commonly used fixative. So let us see a list of other fixatives which are used in pathology. You very well know formaldehyde, most common. This is used for light microscopy, whereas electron microscopy, the fixative that is used is glutaraldehyde. Electron microscopy, glutaraldehyde. Next point, bone marrow biopsy. Bone marrow biopsy, Zenker's fluid. Bone marrow biopsy, Zenker's fluid. Next, gastrointestinal biopsies or GI biopsies, Boyne's solution. GI biopsies or gastrointestinal biopsies, Boyne's solution. Testicular biopsies. Testicular biopsies, Boyne-Holland solution. Testicular biopsy, Boyne-Holland solution. So the fixatives which are used in pathology, light microscopy, formaldehyde, kitna percent? 10%. Electron microscopy, glutaraldehyde, bone marrow biopsy, Zenker's fluid. GI biopsies, Boyne's solution. Testicular biopsy, Boyne-Holland solution. Add one more, pap smears. Pap smears, ethyl alcohol. Pap smears, ethyl alcohol. What percentage of ethyl alcohol? 95% ethyl alcohol. 95% ethyl alcohol. Done. These are the fixatives used in pathology. Next. This gets us to the next question, that is question 69. Seminoma body is not seen in follicular carcinoma thyroid. Follicular carcinoma thyroid. This is easy. So let us have a look at seminoma bodies. Seminoma bodies. First point, seminoma bodies. Is it dystrophic calcification or is it metastatic calcification? It is dystrophic calcification. Seminoma bodies. It is dystrophic calcification. Next point, tumors associated with seminoma bodies. 3 have already been mentioned. Papillary carcinoma thyroid, that is PTC. Next, serous cystadenocarcinoma ovary. Serous cystadenocarcinoma ovary. Next, meningioma. Meningioma. Next, prolactinoma. Prolactinoma and mesothelioma. And mesothelioma. So tumors associated with seminoma bodies: papillary carcinoma, thyroid, serous cyst adenocarcinoma, ovary, meningioma, prolactinoma, and mesothelioma. So the answer to the question is follicular carcinoma, thyroid. This is not associated with seminoma bodies. Next. Question 70. Which of the following is an example of CXC or alpha chemokine? And the answer is interleukin 8. Which of the following is an example of CXC, interleukin 8? So, coming to classes of chemokines. Classes of chemokines. There are 4 classes of chemokines, which are CXC, CC, C, and CX3C. There are 4 classes of chemokines. Coming to the most important point, chemokines, what are they chemotactic for? First, CXC, it is chemotactic for neutrophils. CC is for all leukocytes except neutrophils. All leukocytes except neutrophils. C is for lymphocytes, whereas CX3C is for monocytes. So neutrophils, all leukocytes except neutrophils, lymphocytes, monocytes. Next point, what are the chemokines in this category? Interleukin 1, interleukin 8, TNF alpha. Interleukin 1, interleukin 8, TNF alpha. All leukocytes except neutrophils, eotaxin, monocyte chemoattractant protein 1, and rentis. The chemokines in the second category, eotaxin, monocyte chemoattractant protein 1, MCP1, and rentis. Next, lymphocytes. This is lymphotasin, and last is monocytes, that is fract alkali. Monocytes, that is the last category, CX3C, fract alkaline. Lymphotasin, fract alkaline. So the question was, which of the following is CXC, interleukin 8? These are the 4 classes of chemokines: CXC, CC, C, and CX3C. Next. Okay, this gets us to the next one, that is question 71. Secondary granules of neutrophils are, this has to be remembered, it is a factual question, lactoferrin. I cannot help you with this, this has to be remembered. It is lactoferrin, it is a secondary granule, rest are the primary granules. Next, question 72. An experiment is conducted to determine if cell injury is lessened by vitamin E. So vitamin E, it is an antioxidant. Which cell components is primarily involved in lipid peroxidases? Answer is D, that is ferric iron. That is ferric iron. See, it is obvious. Your options are glutathione. Glutathione peroxidase, that is itself an antioxidant. Next, ionized calcium. Ionized calcium, it is not responsible for free radical injury. Lactate, no, that is an anaerobic glycolysis product. Answer is ferric iron. Ferric iron, this is responsible for reactive oxygen species induced damage. It is responsible for ROS or reactive oxygen species induced damage. Vitamin E ingestion, it is an antioxidant, so it inhibits ferric iron. Next. Question 73. 53-year-old male, cardiac arrest. A thrombolytic agent is given after the cardiac arrest. So which cell process is likely to cause injury? Answer is B. That is, it is going to cause a free radical injury. It is going to cause a free radical injury. Why? C. A thrombolytic agent was given. A thrombolytic agent, it dissolves the thrombus, it lyses the thrombus, as a result of which this in turn leads to reperfusion injury. It in turn leads to reperfusion injury, and you very well know that reperfusion injuries, they are mediated by free radicals. So after thrombolytic agent, it is going to be a free radical injury. The other options, they were extremely out of the question, because apoptosis, it is programmed cell death, that's not going to happen. Heterophagocytosis, no, and why would squamous metaplasia take place? So answer was obvious, free radical injury. Next. This gets us to the next one. Cardinal signs of inflammation. They were described by Cornelius Celsius. You very well know the cardinal signs of inflammation: rubor, choler, dolor, tumor. They were described by Celsius. The fifth sign, that is loss of function, was added by Rudolf Virchow. The fifth sign, that is loss of function, was added by Rudolf Virchow. You know this. Next, question 75. Question 75. Bernard-Sollier syndrome, it is a defect in platelet adhesion. Easy. There are two diseases associated with this: Bernard-Sollier syndrome and Glanzmann's thromboasthenia. Bernard-Sollier syndrome, or BSS, it is a defect in platelet adhesion, because this is a defect in GP1B9 this is a defect in GP1B9 complex, whereas Glanzmann's thromboasthenia, this is a defect in GP2B3A complex, which is responsible for platelet aggregation. So Bernard-Sollier syndrome, it is a defect in adhesion, whereas Glanzmann's thromboasthenia, it is a defect in aggregation. GP1B9 complex, GP2B3 complex. Done. Next. Question 76. Question 76. T banding. It usually selectively stains telomeres. The name tells you everything. T banding, telomeres. Next, let us have a look at major chromosomal staining patterns. Let us have a look at major chromosomal staining patterns. Major chromosomal staining patterns. Starting with the first one, that is GIMSA or G banding. GIMSA or G banding. Dark bands in G banding are AT rich. A forms a double bond with T. They are AT rich, whereas light bands are CG rich. So if you remember it the other way around, double bond hai, so they are dark bands. Triple bond, light bands. Next is the R banding or reverse banding. Reverse or R banding. This is opposite of this. In reverse banding, AT rich areas are light, whereas CG rich areas are dark in color. It is opposite of the G banding. It is opposite of G banding. Next, T banding, that is telomeres. It is a subtype of GIMSA banding only. It is a technical variation for GIMSA banding only. So the question was on T banding. It is used to stain telomeres. Next, this gets us to the next question, that is question 77. Question 77. Easy. Wire loop lesions or wire loop thickenings are seen in lupus nephritis. They are seen in lupus nephritis. So let us see few things about SLE or lupus nephritis. It has 6 classes. So classes of lupus. Class 1 to class 6. Most common class of lupus nephritis, class 4. Most common class of lupus nephritis, class 4, also called as diffuse lupus nephritis. Also called as diffuse lupus nephritis. Next point, microscopically, we are writing the points with class 4 only. Microscopically, class 4, it shows the presence of wire loop lesions. Microscopically, it shows wire loop lesions. Next point, site of deposit. It has a subendothelial site of deposit. Class 4, subendothelial site of deposit. So the question was wire loop lesions seen in lupus nephritis. Next point. Coming to the next question, that is question 78. Question 78. 78. True about molecular iron. It is stored in combination with ferritin. It is stored in combination with ferritin. Nothing to explain in this. It is not stored in spleen. The main site of storage is bone marrow and liver. So liver and the bone marrow are the main sites. Next, site of absorption. Iron, easy to remember, main site of absorption. Iron, folic acid, B12, duodenum, jejunum, ileum. The main sites of absorption are duodenum, jejunum, ileum. Done. Next. Question 79. In Glasman's thromboasthenia, we have just seen this. This is a defect in platelet aggregation. We have just seen Bernard-Sollier syndrome, that is BSS, is a defect in platelet adhesion, whereas Glasman's thromboasthenia is a defect in platelet aggregation. Next point, Bernard-Sollier syndrome, there is a defect in GP1B9, whereas in Glasman's thromboasthenia there is a defect in GP2B3A complex. In Glasman's there is a defect in GP2B3A complex. We have just seen this in the previous question. Next point, question 80. Not seen in Rees syndrome. Rees syndrome, we have seen it in the previous question. It was fatty liver with hepatoencephalopathy, but it is associated with hypoglycemia, with seizures. But the point to be noted is bilirubin. It is not more than 8 milligrams. So answer is bilirubin more than 8 milligram percent. This is not seen in Rees syndrome. Let us see few points with Rees syndrome. It is usually seen in children post-viral infections. Seen in children post-viral infections, fever and after aspirin therapy. So Rees syndrome, children, fever, viral infections. Next point, it causes microvesicular fatty liver. This point again is important. It causes microvesicular fatty liver with mitochondrial injury. It causes microvesicular fatty liver with mitochondrial injury. Next point, in Rees syndrome, prothrombin time, that is PT, is elevated. In Rees syndrome, prothrombin time, that is PT, is elevated. Done. This is Rees syndrome. Bilirubin levels, they are less than 8 milligrams per deciliter.